This lecture is on respiratory pharmacology for Pharm II. The first half of the lecture will be covering oxygen, respiratory stimulants, bronchodilators, corticosteroids, and asthma prophylaxis. Now, I've embedded several videos into the PowerPoint slide presentation, which I won't show on this, but if you want to go to the slide presentation that I've sent you, you can watch the videos that I included. We'll start with oxygen. Oxygen is used primarily in the treatment of hypoxemia. Hypoxemia is just the medical term for insufficient oxygen supplied to the tissues. How it's administered really depends a lot upon, well, the patient and how much oxygen you're giving. If you're giving 5 liters or less, generally you can use what we call a nasal cannula, and I know you've talked about that in your med-surg class. Once you get over 5 liters, you can move on to various types of masks. I'm not going to get into the different types of masks. That's more of a med-surg thing. But I do want to get into side effects of oxygen. A lot of people forget that oxygen is considered a medication, but it is, and like other medications, it has side effects, especially if it's delivered at too high of a concentration or someone's given too much oxygen. It can cause hypoventilation, so low ventilation or low respiration, particularly with COPD patients, and we're going to get more into that in just a minute. And it can also cause blindness in premature infants and changes in alveoli to the lungs. So if you can, watch the videos I've included from the PowerPoint, but I will summarize them. It's about giving oxygen to the COPD patient. Now, there are some nursing schools or nursing instructors that will stress that if a patient has COPD, they can get no more than 2 liters of oxygen. And that is treated like a rule rather than a recommendation. And it is not a rule. It is a recommendation. And so if you're a medical assistant or a CNA, that's a good guideline that the patient you're caring for shouldn't be on more than 2 liters, and if they're still not doing well respiratory-wise, that's a good indication to go get the nurse. But if you are a nurse, we should know by now that there are no, for certain every single time, rules like that it's a guideline. But if your patient is hypoxemic, meaning insufficient in oxygen, they're turning blue, their respiratory rate is high in the 30s, they're gasping for breath and saying, I can't breathe, and you check their O2 stat and they're 80%, just because they're on 2 liters of oxygen, you don't just say, well, I'm sorry, you have COPD, 2 liters is all you get. No, they can have more. We just have to be cautious about it. We can't just give someone with COPD a whole bunch of oxygen without repercussions. So give them as much oxygen as they need to get their SATs back up and to relieve the respiratory distress. And so there is no really limit. Of course, we're going to call the doctor, but you don't want to call the doctor while your patient's in distress. You want to get them out of distress first, then call the doctor. Tell the doctor, I had to turn them up to 4 liters. Now they're satting 88%, and then go from there. So yes, they can have more than 2 liters. The problem we run into with COPD and oxygen is that we have 2, we'll call them drives. We have an oxygen drive and a CO2 drive, and this is a very simplified explanation, but those are the 2 things that trigger our brain to breathe, to take a breath. And at rest, most people are a little bit more reliant on the CO2 drive, meaning that when your CO2 levels get too high, it sends a message to your brain that you need to breathe and blow off some CO2. And so that's where we get our respiratory rate, which you should know by now is you want that to be like 12 to 20, right? It's the usual recommendation. Well, on people with COPD, they've been trapping CO2 for a long time. And so their body's kind of used to that. And so they don't actually lose their CO2 drive, but it's diminished. And so they're going to function on what we call an oxygen drive more than the non-COPD patient. And so instead of their body saying, we need to get rid of CO2, take a breath, their body says, we need some oxygen, take a breath. And that everyone has an oxygen drive. You'll especially notice it when you're exercising. Your oxygen drive takes over because you need more oxygen to exercise. Well, the COPD patient is more reliant on that oxygen drive. So if you hit them with a high level of oxygen, you can knock out their drive to breathe, their respiratory rate. But when you're a nurse, you don't have to be so scared of doing that you don't give them any oxygen. Real simple. Give them the oxygen they need and monitor them. Watch their respiratory rate. If their respiratory rate drops down to 10, let up on the oxygen. But we're not going to just crank up their oxygen and then leave and not assess them again for 4 hours. We're going to be monitoring them. They're in respiratory distress, so they need to be watched really closely and monitored. We're also going to watch their oxygen saturation real closely. Now here is a big difference. It's not so much that COPD cannot have more than 2 liters of oxygen. What you do want to watch out for is that your COPD patient does not need to be saturating 97, 98, 99% like most people do. Most doctors are going to be pretty happy with an 88 to 92% oxygen saturation, and some doctors might not even want their COPD patient being over 92%. And it again has to do with what I just explained, that whole switch from an oxygen drive to an oxygen drive primarily from the CO2 drive. And so we're going to accept lower oxygen saturation levels on our COPD patient without getting upset about it. So if you do turn them up to 4 liters, let's say, and you go back and check, and let's say their oxygen saturation is now at 98%. That's a pretty good indication that you can turn down that oxygen and try to get them back to the 2 liters that was ordered. You do need to get a doctor's order whenever you mess with someone's oxygen levels, but you certainly are in the right to fix the problem first, get the patient where they're breathing and they're no longer hypoxic, and then call the doctor, tell the doctor what you did and why, and if the doctor wants to have any more orders. The last thing about oxygen is the cautions, and just knowing that it's not particularly what you'd call flammable, but it does support combustion, so you don't want to have it around any candles or smoking or anything that could be a fire hazard. Your textbook briefly touches on, oops, there it went, respiratory stimulants. Caffeine citrate, which is used in neonates, infants, who are having some respiratory problems, maybe because they were born prematurely or whatever. And then theophylline is another respiratory stimulant that's actually in the xanthine category. That we'll talk more about that in a little bit. But theophylline used to be used a lot when I first went into nursing, but I don't see it too much anymore. It has a lot of fairly nasty side effects. But it is used. One thing that you do hear a lot of are Cheyne-Stokes respirations. And I was asking my students today about Cheyne-Stokes respirations, and they had no idea what those were. And I thought, oh my gosh, you're seniors and you don't know? And when I spelled it for them, they're like, oh, you mean the Cheyne-Stokes. I'm Cheyenne, but anyway, it's Cheyne-Stokes. They just didn't know how to say it. But it's the same thing. And if you've never seen that, once you see it in a patient, you'll never forget what it's like. But it's periods of apnea followed by almost a panting, like what a dog would do. And it's often described in textbooks as with musical terms, crescendo, decrescendo, so slowing down and getting faster. But here's a real quick what it looks like. Apnea, apnea, apnea. So you pause breathing, and then it's like your body plays catch up, and you take maybe 12 breaths super fast and then pause breathing again. And it's really scary to watch. And normally patients that are having Cheyne-Stokes respiration, they aren't doing so good. But theophylline is one of the things that's used to treat that. Again, in the slide presentation that I sent to you, there's a link where you can watch a video that explains it a little bit better than what I did. So the next thing I wanted to talk about is bronchodilators. And this is a pretty big category. Bronchodilators are going to relax the smooth muscles of the bronchial tree. Now, it's been a while since you had your A&P, and so maybe you might have forgotten possibly just what are those smooth muscles. I know I do sometimes. But just to review, we have 3 basic types of muscle. Some people, if you're really into A&P, they can break it down even more, but I'm going to say 3. Skeletal, we don't care about this unit. Cardiac, we'll worry about in Pharm 4 when we do cardio. And then smooth muscle, bingo, that's what we're talking about. Smooth muscle is often called involuntary. That means we can't control it. Skeletal muscle, we can control, right? The other thing about smooth muscle is a lot of times it's going to do the opposite of what the skeletal and cardiac muscles are doing, because our bodies are not great at multitasking. Places where we might see smooth muscle, just a reminder again, you had this in A&P, the walls of the blood vessels, the bladder, the uterus, different parts of the reproductive tracts, your GI tract, which is going to come into play, as well as respiratory tract in this chapter, skin, the iris of the eye. And so if you're having a bronchodilator, you're also going to have a pupil dilator too. So the purpose of bronchodilators is to relax the smooth muscle, which will relieve some bronchospasm and decrease the work of breathing. So think of it as having a garden hose, and you're just going to make the opening of your garden hose bigger. So instead of constricting, the muscles are going to open up. Bronchodilators are, I would have to say, the mainstay of respiratory treatment. We use those for everything. That's like the cure-all for everything, is dilating those bronchioles so people can breathe better. So one class of bronchodilators are called sympathomimetics or adrenergics. And I explained in the class that I used to take my kids to the zoo all the time. I had a zoo pass. And I hated driving there because it was real difficult. But someone finally showed me a way, because I live in way far north, this really simple way to get there. And I never knew that way because it turns into Martin Luther King Avenue. And is Martin Luther King Avenue called Martin Luther King Avenue everywhere? No. In fact, from my house, it starts out as a little blacktop called Broadway Road. Then you reach Edmond, and guess what? There is a Broadway in Edmond, but it's not Broadway Road. Broadway Road turns into Boulevard. And so you go on Boulevard through Edmond, same road, just different name. And then, for some reason, when you cross Memorial, it turns into Eastern. Same road, different name. So then you go along until you get to, what's that school? They're kind of by the zoo. Well, I can't remember what it's called. But anyway, at Millwood, yes, I have students in here. And you get to about Millwood, and then it changes again to Martin Luther King Jr. Avenue, and then you're at the zoo. Well, I never knew they were all the same road because they all have different names, but it's the same thing. Well, long story short, or short story long, a lot of the bronchodilators, there's a whole bunch of different terms for them. Sympathomimetics, sympathetic nervous system, adrenergics. They're all meaning the same thing. And why there has to be 5 different names for the same thing, I don't know, but there is. And so sometimes it can seem confusing, and you think the central nervous system or the autonomic nervous system is real complicated because there's all these parts, but really there's just 2. Just the 2 parts have 5 different names. So when I say adrenergic or sympathomimetic, meaning it's mimicking the sympathetic nervous system, I'm talking about all the same thing. And if you look at this word, you see the word E-N-E-R-G-I. And what does that remind you of? The word energy, right? And so that's your key to what part of the autonomic nervous system this is. This is the fight or flight, the energy part that's going to activate all of your skeletal muscles and get your blood pumping and your heart pumping, and what happens when you're being chased by a bear or whatever. And so that's good to know because that also helps you know what the side effects of all these medications are. You're going to have elevated heart rate, and your pupils are going to dilate. All of the things that happen with the adrenergic part of your body are going to happen when you take a bronchodilator. We just hope it's not that the benefit outweighs the risks. So here I have 2 pictures of Scooby-Doo, and you're thinking, why is Scooby-Doo in this video? Well, one of these, Scooby-Doo is my favorite adrenergic cholinergic example, and in one of these, Scooby-Doo is doing his adrenergic response, his fight or flight, and in the other, he's doing the cholinergic. So which do you think is the adrenergic? If you said that one, you are correct. When Scooby-Doo's running from monsters, he's demonstrating the part of the central nervous system that we term the sympathetic nervous system or the adrenergic response.